Hi, my name's Rachel Poulton. I'm going to be talking to you today about the adaptations to extrauterine life. So essentially this is what we're going to cover: the transition from the fetus to the newborn and all the anatomical and physiological processes that go along with that. So first of all, if I put a bit of clinical basis around this, the way we assess a newborn baby is by something called the APGAR system. It's a scoring system and it allows us to see if a newborn baby is adapting as they should to the outside world. So how this is done is a baby is scored at 1, 5 and 10 minutes using this mnemonic. So A is for alertness, P for pulse, G for grimace, A for appearance and R for respiration. The maximum score you can get is 10 and the minimum score you can get is 0. So let's work through an example. So this is a newborn baby at 1 minute of life. And if we work out the APGAR score for this baby, this is an uncomplicated newborn baby. So look at this baby. So babies are normally born blue. That gives the baby a 1 in the appearance, so pale or blue in the hands and feet. The baby's very active and alert, giving them a 2 for alertness. The pulse is above 100 beats per minute, and that's usually normal for a baby. Sometimes it can be a bit lower, but by 1 minute it should have come up. They're usually crying, as you can see in this picture. And the respiration after a good first breath is usually a good, strong, regular respiratory effort. So in this baby, instead of getting the maximum 10, we'd give them a 9, because they dropped 1 for the blue hands and feet, which is normal for a baby. So let's go back to baby inside mum, the fetus. So inside mum, with regards to respiration, when the baby is in the womb, it breathes by exchanging oxygen and carbon dioxide through the mother's circulation via the placenta. Most of the blood doesn't go through the developing baby's lungs. Instead, it travels through the heart and flows throughout the baby's body and then back to mum. So mum does all the work essentially. So the first breath is a particularly important event for the baby. The passage through the birth canal is a hypoxic event for the baby. During a normal vaginal delivery, the lung liquid is reabsorbed by the lymphatic and pulmonary system, and the active squeezing of that chest allows the fluid to be expelled from the trachea. It can take quite a long time for this fluid to be reabsorbed after a cesarean section, for example, where you don't get that active squeezing process, which is why some babies can run into trouble with extra fluid on their lungs. We call this transient tachypnea of the newborn. Other changes that happen: so when the baby is born, there's a sudden change in the baby's environment. This helps the baby to take its first gasp. So this is the first major step that's required to begin the adaptation to extrauterine life, this first gasp. The first gasp happens at around 6 seconds after delivery, followed by regular breathing at about 30 seconds. So this slide specifically talks about the adaptation of the lungs, and as you can see on the left, the lungs or the alveoli are filled with fluid, and in that first gasp you push fluid from the airway and alveoli out, and the baby takes its first gasp, fills the lungs with air, and you establish a resting lung volume. So clamping the cord is another vital part of the transition of the baby into the outside world. So this is one of the first things that has to happen as soon as the baby is born. The baby has to be almost detached from mum. And they do this by cutting the umbilical cord. So before birth, the baby's circulation, which we'll talk about in a second, is reliant on the placenta. Therefore, by cutting the cord, it allows the transition from the placental circulation to the neonatal circulation, or the newborn circulation. We'll talk about this again in a couple of slides. In an uncompromised, well baby, it's actually now recommended that the cord clamping should be delayed by about 1 minute from the complete delivery of the infant. This has been shown to reduce the risk of iron deficiency later in life. So this is quite a busy slide, but essentially it just shows that there's a lot of things that happen simultaneously after the baby takes its first gasp. So this is taken from 2 slides ago, where the lung or the alveoli is now full of air. And there are 3 major things that happen. So the reflex gasping at birth that we've just covered generates a really high intrathoracic pressure. That allows air to enter the lungs. So this generates changes to start happening in the newborn. The rise in oxygen and the mechanical stretching allows pulmonary dilatation and a drop in the pulmonary vascular resistance. The drop in the pulmonary vascular resistance is needed to allow the blood to return to the left side of the heart and to rise the pressure in the left side of the heart and to close that foramen ovale, which is something that we'll discuss in a couple more slides. Both of these changes allows the ductus arteriosus to close, which is something that again we're going to cover in a couple of slides. So this is the fetal circulation. It's a bit of a complicated diagram, but it really simplifies what goes on in the fetus. So like we've just mentioned, the main organ of gaseous exchange is that placenta, which is down at the bottom left of the diagram. Blood bypasses the lungs via the foramen ovale and the ductus arteriosus. So let's go through step by step. So the circulation from the fetus is very different from the neonate, which is why we're going to describe both in different slides. In the fetal circulation, the placenta is doing all the work that the lungs will eventually do after birth. So the 2 main points to take from this slide are these that we've just mentioned on the left, that the placenta does the most of the work and that blood bypasses the lungs through 2 holes that will eventually close in the baby. So the placenta accepts the deoxygenated blood from the fetus through 2 umbilical arteries. Gaseous exchange then happens via the placenta and the oxygenated blood travels back to the fetus via the umbilical vein. The blood travels via the ductus venosus, which is down by the liver there, up to the right side of the heart. But blood then passes through that hole between the atriums, which we call the foramen ovale, into the left side of the heart, where it then gets pumped to the rest of the body via the aorta. This ensures, essentially, that the brain and the cardiac muscle get the most oxygenated blood they can via the carotid and the coronary arteries. So after the blood's been circulated around the heart and around the head, it comes back to the heart via the superior vena cava back into the right atrium. Some of the blood does pass into the right ventricle. However, this blood can still bypass the lungs via other fetal connections between the pulmonary arteries and the descending aorta. This is the ductus arteriosus. The reason most blood passes this way is because the pulmonary vascular resistance is extremely high in the fetus, and it has to be, because you don't want blood going to the lungs because they're not being ventilated. The blood is quite straightforward. It follows the path of less resistance in a fetal circulation, which means it wants to go via the aorta through those holes instead of going to the lungs where the pulmonary vascular resistance is high. The blood then exits the heart and supplies the lower half of the body, and thereafter returns to the placenta via the umbilical arteries to start the process all over again. So this slide essentially just summarises what we've already covered. So the cord is clamped and the baby takes its first breath. That's really important. The lungs inflate and they begin working on their own, moving oxygen into the bloodstream and removing carbon dioxide by exhaling. The pulmonary expansion at birth is associated with a fall in the pulmonary vascular resistance, This allows for the pulmonary blood flow, so allows blood to now flow into the lungs and be oxygenated. This then increases the blood returning to the left side of the heart, which increases the left atrial pressure, creates a pressure gradient between the two atriums, and allows that foramen ovale to close. The flow of oxygenated blood through the ductus arteriosus allows physiological and eventual anatomical ductal closure, which is important, and we'll cover that in a minute. So these are the changes that happen at birth. It almost looks this slide looks very similar to the previous one, but we'll show all the changes that happen. So first of all, the baby is born and the cord is clamped, so these umbilical arteries are clamped. As we discussed, the baby takes its first gasp, and this allows the lungs to inflate, so they've turned blue on this diagram. As the lungs inflate, this causes the pulmonary vascular resistance to fall and allows more blood to pass through to the lungs. This causes an increase in the blood returning to the left side of the heart or the left atrium, causing an increase in the pressure. As we mentioned before, this causes a pressure difference across that foramen ovale and allows it to close, thereby causing the blood to flow to the left ventricle and thereon up into the aorta and perfuse the rest of the body and the head. So this ductus arteriosus, which is labelled in this diagram, is now exposed to oxygenated blood, whereas previously in the fetus it was exposed to deoxygenated blood. Because of this, the ductus arteriosus is stimulated to close, and you get a physiological and then an anatomical closure of the duct. So the ductus arteriosus clinically is quite important for a newborn baby, and there are lots of things about what causes it to stay open and what can cause it to close. So let's cover the closed side of things first. That's a little bit more straightforward. So for a ductus arteriosus to close, well, things that can cause that is just the normal postnatal adaptation, which we've just discussed, where the ductus arteriosus is exposed to oxygenated blood and therefore is stimulated to close. Other times it can be closed is when it's exposed to a prostaglandin inhibitor, such as an NSAID, such as ibuprofen. This can cause a duct to close, and you might use this to try and medically close the duct in a baby. The other more definitive way of closing a duct is surgical ligation. This can either be done through an open stenotomy or by a catheter. Things that might cause the duct to stay open, well, if you've got a very premature baby, that can cause the duct to remain open. If a baby's got a cyanotic congenital heart disease, the baby can be reliant on this ductus arteriosus and can remain patent for some time. And sometimes you might even try and keep the ductus arteriosus open, but that's for a different talk some other time. Other things that can keep this ductus arteriosus open are maternal infections, namely rubella. So you might wonder if mum had been exposed to this if you had a baby with a patent ductus arteriosus. And other things are genetic abnormalities, such as trisomy 21 or Down syndrome and Noonan's. These are classically associated with patent ductus arteriosus. So we've now covered the main things that happen when the baby comes from fetus to newborn baby, namely the changes in the respiration and the changes in the cardiovascular system. They're really important and really key. Now there are obviously a number of other things that change in a newborn baby, and I want to just touch upon them. So we're going to cover changes that happen with thermoregulation, renal, the hepatic system, gastrointestinal, the metabolic system, hemopoietic system, and finally the immune system. So first of all, thermoregulation. So as I've already discussed, it's the changes in the environment, initially when the baby's born, that cold stimulus, that's one of the factors that stimulates the baby to breathe and take its first gasp. It's important to help the newborn regulate their temperature after this happens, as a large surface to body mass causes a rapid heat loss and the babies can run into trouble. So babies can lose heat in 4 ways. So they can lose heat via conduction, where if you put a baby on a cold surface, they'd lose heat that way. They can lose heat by evaporation, so they get a transepidermal loss, especially in preterm babies. That's really important. They can lose it by convection, so if they're exposed to a cool draft, and by radiation. And by this I mean there can be a temperature difference between the skin and surrounding surfaces, like an incubator wall, for example. So all of these ways can cause a baby to lose heat really quickly, as there's a large surface to body mass in the newborn, so it's important to try and control these. So this is how we control it. So to help a baby to thermoregulate, there are a number of things that we can do to ensure the heat loss is kept to a minimum. So with regards to the radiation, in the top left, well, we dry the baby. With regards to the convection, we nurse a baby in a closed environment, such as a cot or an incubator, so you avoid drafts in the baby. So to avoid evaporation, we wrap the baby as soon as the baby comes out. And to try and avoid conduction, we use a really nice warm towel for the baby to be wrapped in. So if these things aren't done, what happens? So if the baby's still cold, the baby will obviously lose heat by all of these 4 ways and will lose heat really quickly. The receptors on the baby's skin send messages to the brain that the baby's body is really cold. The baby can conserve heat by adopting a curled up position to insulate themselves, and they vasoconstrict the skin to avoid heat loss. They can also make heat by shivering and by burning their stores of brown fat. This is a type of fat that's only found in fetuses and newborns. So this will burn the energy stores and can cause a lot of problems for the baby, because these energy stores are essential glucose stores that the baby needs in the first few hours of life. So if they become hypothermic, i.e. below 35 degrees centigrade, the newborn can increase in mortality and morbidity because of these reasons. So the baby will have an increased oxygen consumption with hypoxia. They'll become hypoglycemic and they'll develop a metabolic acidosis, which can create a systemic problem for the baby. If they become cold, they can become apneic, so they can stop breathing. And this might be the only feature that you see on a baby before you take their temperature. So if a baby's cold, they'll also be using up a lot of their energy stores to try and stay warm, so they won't gain weight effectively. The baby can also have a neonatal cold injury, or on the other side of the spectrum, sclerema. They can also have problems with their blood coagulability. So as you can see, it's really important to keep a baby warm. So let's talk about the renal adaptations. So a newborn's GFR, so that's the rate which the blood flows through the kidneys, is low compared to the adult. However, it rises quickly in the first 2 weeks of life. A newborn will start to urinate by about 24 hours of life, and the kidneys become able to recognise the bodily fluid and electrolyte balance. In the first 2 weeks, there's a marked reduction in body water or extracellular fluid, and this causes that initial fall in the body weight, as you can see on this growth chart, just marked there in the black. You get an insensible water loss as well in babies, so you get transepidermal water loss, which is very high, especially in preterm infants. Therefore, it's important to nurse them in humidified incubators. All of this nephrogenesis is complete by about 35 weeks. So the hepatic or the liver adaptations. So in the fetus, the liver acts as a storage for sugar or glycogen and iron. When the baby is born, the liver has various functions. So it produces clotting factors, such as the vitamin K dependent clotting factors. It begins breaking down waste products, such as the excess red blood cells that the baby's got circulating around their body that they don't need anymore. It can produce a protein, so this long name, glucuronidyltransferase, and that helps break down bilirubin. If the baby's body does not properly break down the bilirubin, that can lead to neonatal jaundice. Before birth, this enzyme is actively downregulated, so it's actively not produced, because the bilirubin in the baby, or in the fetus, needs to remain unconjugated in order to cross the placenta and avoid being accumulated in the fetus. After birth, this enzyme is then upregulated, and it can take some time for this to happen. So the change in the gastrointestinal system. So a baby's gastrointestinal system doesn't fully function until after birth. In late pregnancy, the fetus produces this tarry green or black stool called meconium. And that meconium is made up of things like amniotic fluid and mucus and lanugo, or that fine hair that covers the baby. Also bile and cells that have been shed from the baby. This is called meconium, and is important for the baby to pass meconium in the first 48 hours of life. Sometimes the babies will produce this meconium during the late stages of labour when they become distressed. If the baby doesn't pass meconium in the first 48 hours, questions are raised over the functionability of the baby's gastrointestinal system. Diagnoses such as Hirschsprung's disease comes to mind and start getting investigated for them. So the metabolic system. So as I've mentioned, the fetus is entirely dependent on that transplacental nutrient transfer from the mum. When the baby is born, the blood glucose falls really quickly. It reaches its lowest at 1 hour of life and rises again by about 3 hours. The insulin level falls after birth and allows for a surge of glucagon in response to the stress of birth. This mobilises the liver glycogen and allows the glucose level to stabilise out. So it's important to establish a first feed within an hour of birth for this reason. It's especially true for babies who have a risk for developing hypoglycemia. Such babies are those born to mums with gestational diabetes. These babies have been exposed to high sugars throughout pregnancy, therefore have had high insulin fetal levels intrauterine. At birth, these insulin levels are still persistent or still present. However, the baby is no longer exposed to the high blood sugars from mum, therefore it can further drive the newborns to become very hypoglycemic, and again they can run into trouble with that. So gestational diabetes. So like I said, it was important to establish that first feed within an hour of birth for this reason. So this diagram shows what happens for a normal neonate compared to one that's been exposed to high blood sugars. So on the left of the diagram, it shows a normal neonate. The baby is born after a normal or low exposure to blood glucose intrauterine. The baby is born and the sugar levels drop further. This stimulates the pancreas to release glucagon, which stimulates the liver to release stores of glucose. This allows for normoglycemia within hours of birth, which is great for the baby. Now, if you look at the right side of the diagram, these babies have been exposed to high sugars throughout pregnancy, and therefore have had high insulin release from the fetal pancreas intrauterine. After birth, these insulin levels persist without the intrauterine exposure to high blood sugars from mum. Therefore, the high insulin levels produced from the baby's pancreas can drive the newborn sugars to become very low. This can take some time to switch off and normalise. Therefore, these babies will have their blood sugars actively monitored and sugar replaced where needed for the baby. So gestational diabetes is quite important for a newborn baby. So I just wanted to cover the other sorts of problems that babies can run into when they're born if their mum had gestational diabetes. So the first thing to say is that there's a much higher risk of miscarriage and stillborn if mum's blood sugars aren't very well controlled. So it's important to get on top of these. At birth, babies are known to be very large if they're born to mums with gestational diabetes. This can cause problems to get the baby out and can lead to a very difficult delivery, and sometimes can cause hypoxic injury to babies. If mum has had gestational diabetes, the baby can go on to have a prolonged jaundice, which can cause problems for the babies. Babies may also, at birth, show signs of respiratory distress of the newborn. And that's due to both prematurity that they're exposed to and something called transient tachypnea of the newborn. And gestational diabetes is the high sugar that the baby's been exposed to that allows or that switches off the surfactant production in the baby, which can cause respiratory problems of the newborn. Also, you've got the babies that are born by emergency C-section because of the difficult delivery. Therefore, those babies won't go through that natural process through the vaginal canal and won't get the fluid expelled from their lungs as a newborn, normal delivery baby would do. So they're also at risk of this transient tachypnea of the newborn. Other things for completeness that babies have if they're born to mums with gestational diabetes is cardiac problems. Often they get something called interventricular septal hypertrophy, so just the septum between the ventricles can become quite hypertrophic. This can lead to problems in the baby initially, however quite often it's something that's just monitored and eventually normalises. So hematopoiesis, you've probably covered this in some of your more scientific talks earlier on in your medical school life, but the hemopoietic changes throughout fetal life to the newborn are just summarised here. So the embryonic hemopoiesis begins in the yolk sac, and by the end of the first trimester predominates in the liver, and then bone marrow hemopoiesis begins at about 5 months gestation, and this eventually becomes the main site after the birth. So in the fetus, there's predominantly fetal hemoglobin, or HbF. HbF, as you can see on the diagram on the right, has a higher affinity for oxygen, and this is an advantage for the fetus who's in a relatively hypoxic environment. This shifts the oxygen dissociation curve to the left, as you can see in the diagram. And there is a change from fetal hemoglobin, or HbF, to HbA from late fetal life to about 6 months of age. And this is gradual, this change. The hemoglobin concentration is also high at birth. Newborn infants, for example, have a HbA of about 15 to 23, which is much higher than a baby of about 1 to 2 years of age. This reflects the asphyxic type environments that the baby is exposed to during fetus and birth. They need more red blood cells travelling around their body to carry more oxygen. The hemoglobin level increases in the first day of life due to extracellular fluid loss, and this is exacerbated by delayed cord clamping, as we discussed a bit earlier on. So the last thing I want to cover is just the immune system. Essentially, these are the 3 most important bits without going into too much detail. So the first thing is to say that maternal IgG, or immunoglobulin G, crosses the placenta in the 3rd trimester. This is passive immunity. And this is important because if you've got a premature baby, they've missed out, or an extreme premature baby, they've missed out on this placental transfer. And it's important also that if a baby's breastfed, that they continue to have this transfer of immunoglobulins to the baby for passive immunity. Also, the baby's infection response is a pro-inflammatory response. By this I mean that if a baby has an infection at birth, they have lots and lots of release of things like cytokines, toxic oxygen radicals, potent proteases, lots of things that is very pro-inflammatory. The reason behind this is quite unclear, but it's thought to produce end organ damage if it's severe. So it's important to get on top of infections in newborn babies. The newborn acquires adaptive features as a result of exposure to the microbes, and this happens as the baby gets older. This is due to the development of their B and T cells as part of their immune system. And that's it. So what we've covered is the transition from the fetus to the newborn, and the anatomical and physiological changes. Most important, the respiratory changes and the changes to the circulatory system. It might be worthwhile going over those couple of slides again with regards to the circulatory system. But essentially it all happens with that first breath. That's the key to beginning this transition into the newborn period. Thank you.